Despite the diversity of the clinical presentation in the cases we have cited, we consider it possible to highlight the common feature characterizing this entire group of schizoid psychopathies. This consists of the following. 1. A peculiar type of thinking. A. Tendency towards the abstract and schematic. Introducing the concrete does not enhance thought processes, but rather complicates them. B. This distinctive feature of thought processes is often combined with a tendency toward excessive reasoning and absurd rumination. See cases 1, 2, 3, 4, 5. The latter often stamps the personality with an air of eccentricity. 2. Autistic temperament. All the children in this group keep to the fringes of the social world. They struggle to adapt to it and never fully merge into it. Upon their admission to the school, cases 1, 2, and 3 immediately become the object of general mockery among the other children. Cases 4 and 5 command no authority among their peers and bear the nickname talking machine, even though, in terms of general aptitude, they rise significantly above the rest of the children. Case 6 even avoids the company of children, which traumatizes him. A tendency towards solitude and an aversion to social contact can be observed in all these children from early childhood on. They keep apart from others, avoid group games, and prefer fantastic tales and fairy stories. 3. In the realm of the thymopsyche, a certain flattening and shallowness of emotions, cases 2, 3, 5. The latter often combines with what Kretschmer has extremely aptly termed the psychoaesthetic proportion of mood. This mixture of anesthetic and hyperesthetic elements can be observed in all of our cases. In case 1, we observe a simultaneous affective indolence and an exaggerated sensitivity. In case 2, an irritability heightened to the point of intense affective explosions, coupled with a pronounced affective indolence, precisely what Bleuler termed affective spasm and affective paralysis. Case 5, calm general emotional tone, affective inertia, and, at the same time, an exalted tenderness towards certain close individuals. Case 4, a peevish, surly misanthrope, and a tenderly loving son. 4. Further distinguishing features follow, including A. The tendency towards automatism, cases 1, 2, 3, 4, and 6, which manifests itself in clinging to the work already begun and in the rigidity of the psyche, which is difficult to adapt to the new. B. The impulsive, absurd actions, cases 1, 2, and 3. C. The silly behavior, the tendency to rhyme, to stereotypical neologisms, cases 1, 2, 3, 5. D. The tendency towards obsessive-compulsive states, cases 1, 2, 3, and 4. And E. The heightened suggestibility, cases 1, 3, and 6. We did not observe any pronounced negativism. Unmotivated obstinacy was present in 2 cases, cases 5 and 6. 5. In all our cases, marked motor weakness was observed, clumsiness, awkwardness, angularity of movement, numerous superfluous movements, and synkinesia, cases 1, 2, 3, and 4. Deficiency of facial expressions and expressive movements, mannerisms, cases 1, 4, and 5, slouching posture, cases 2, 4, and 6, linguistic peculiarities, poorly modulated speech, cases 1, 2, and 3. As for the question regarding the relationship between body build and psychological structure, our observations appear to confirm the somatopsychic syndrome identified by Kretschmer. All our schizoid subjects are asthenic in body build. However, if we consider that our material belongs predominantly to the prepubertal and pubertal age groups, where asthenic dysplastic types prevail even in normal cases, we can hardly attribute any significance to our observations in this regard. The same must also be said regarding the combination of schizoid constitution and tuberculous intoxication frequently encountered among our subjects. This combination is by no means distinctive, since a high percentage of children with tuberculosis is also found among the other groups. The symptomatology of schizoid psychopathies described by us approximates that which Kraepelin attributed to the type of eccentrics he defined, and which Kretschmer ascribed to the group of schizoids. The fundamental characteristics of the schizoid type, identified by Kretschmer, autism and psychasthenic proportion, are also present without exception in all of our cases. However, what is most characteristic in our cases, and what has consistently served as a basis for differential diagnosis, are the peculiarities of the motor sphere and the pronounced motor impairment. Should these observations be confirmed in a large clinical series, they might prove significant for resolving the question regarding the biological pathogenetic substrate of schizoid psychopathy. The motor impairment, accompanied by a whole range of other symptoms, such as a certain weakness in facial expressions and expressive movements, as well as specific peculiarities of speech and voice, could be regarded as an anomaly in the development of certain brain systems. Thus, it would be possible to establish a biological pathogenetic foundation for the concept of the schizoid based on clinical facts. Our observations are too few in number to allow for any conclusions to be drawn, but they suffice to justify raising such a question. The differential diagnosis of cases of schizoid psychopathy must be pursued in several directions. Even the less severe of the cited cases must be distinguished from the norm. Isolated schizoid peculiarities are a not uncommon phenomenon even in normal children. Children often tend to make grimaces, repeat the same word over and over in a stereotyped manner, coin new words, and so on. Many authors point to the presence of catatonic features in children, a tendency toward perseveration, echolalia, stereotypy in drawings, etc. Wildermuth draws a parallel between the schizophrenic splitting of personality and that state of affective splitting observable in the normal child during play. Symptoms of negativism and heightened suggestibility occur more frequently in childhood than other life stages. Schizoid characteristics are particularly prominent and abundant during the so-called critical periods of childhood. In this regard, the ages of 3 to 4 years, and in particular, the age of puberty, should be highlighted. The clinical picture of pubertal changes strongly resembles the symptomatology of schizoid psychopathies described above. Puberty is characterized by a turning away from reality, heightened fantasy, and an inclination toward the abstract, philosophizing, and brooding. The period of philosophical intoxication, according to Zien. Zien, Lange, K. Schneider, and other authors point to a number of catatonic symptoms occurring during puberty, a tendency towards stereotypy, affected and bombastic style, and peculiar sentence construction. Lange points to the silly behavior, affectation, and shyness of girls, and to the coarseness, the rejection of all customary traditions, and the tendency to occupy themselves with lofty problems, etc., among boys. In terms of somatic characteristics, the period of puberty resembles the picture described for schizoid psychopaths: asthenic body build, dysplastic features, uneven development of individual limbs, predominance of lower body length, etc. A characteristic feature of this period is also the disturbance of motor function. Movements are clumsy and angular, and during this time, children drop things, knock things over, frequently stumble, and so on. We find an in-depth discussion of this question of the motor crisis in Hamburger. He notes that all these disturbances closely resemble what we observe in schizophrenics, and regards them as disorders of the extrapyramidal system. During puberty, this disorder is temporary, whereas schizophrenia is permanent. The aforementioned overview of pubertal changes makes it clear that they can easily be confused with schizoid psychopathies. In all our cases, the schizoid characteristics originate in early childhood and cannot be interpreted as psychophysical peculiarities of the period of puberty. Furthermore, in the differential diagnosis of schizoid psychopathies, it must be taken into account that individual schizoid symptoms can also arise from exogenous causes. This category primarily includes psychopathic personality changes resulting from encephalitis, other brain disorders, and intoxications, drug addictions. In pediatric practice, one frequently observes profound personality alterations, manifesting as a schizoid symptom complex, that arise under the influence of persistent psychogenic factors, such as an adverse environment or poor upbringing. This group includes children who lived in poorly organized children's homes from an early age and had to do without loving care. Emotional blunting and negativistic behavior can often be observed in them. In the majority of our cases, the exogenous factor can be ruled out based on a thorough study of the patient's history. In the absence of pathogenic factors such as brain disorders, intoxications, or the influence of an adverse environment, the symptoms, all of which have been present since early childhood, remain static. In more severe cases with pronounced schizoid symptoms, the question of distinguishing them from schizophrenia arises. We ruled out the schizophrenic disease process due to the absence of signs of progression. In all of our cases, the schizoid symptoms had their onset in early childhood. Their further development paralleled their personality growth and gave no grounds for diagnosing a schizophrenic episode. In none of our cases did we encounter an intellectual impairment that might have aroused a suspicion of schizophrenic deterioration. All our cases were under observation for several years, and significant progress was noted in every instance. In Case 1, there are significant advancements in the fields of music and painting. Case 2 shows good academic performance and is becoming significantly more balanced in terms of character. Despite all his eccentricity and quirkiness, Case 3 is making good progress at the Musical Institute. The schizoid types have not yet been described in the literature concerning childhood psychopathies. Rinderknecht describes several cases from Bloiler's clinic that share certain traits with schizoid psychopaths. All these cases are over the age of 16. These are all subjects in whom autism, a tendency toward negativistic behavior, and frequent states of hebephrenic or catatonic agitation could be observed in early childhood. After puberty, antisocial tendencies began to manifest themselves. The author designates these cases as criminal heboids and assigns them to a specific subgroup of schizophrenia characterized by the absence of a progressive course and of an outcome involving dementia. The type of antisocial subjects described by Meggendorfer under the designation parathymia also bears a resemblance to the cases described by Rinderknecht. Here, too, the author considers these cases to be a special subtype of schizophrenia. In this final work, the concept of schizophrenia is, as in Rinderknecht's case, also understood in a very broad sense. If one were to proceed from such an expanded conception of schizophrenia, our cases, too, could be classified by some authors as latent or mild forms of schizophrenia. However, the question arises as to whether such an expanded conception of schizophrenia would actually benefit clinical psychiatry, whether it would facilitate psychiatric diagnosis or lead to an even greater confusion and conflation of terms. Recently, the question regarding the delimitation of schizophrenia has been raised anew, as the concept of schizophrenia is turning into a piece of common currency. Ewald. In analyzing our cases, we proceeded from the view of schizophrenia that regards it as a disease process with a distinct tendency toward the destruction of the personality. Our patients exhibited no features that would have justified their inclusion in this group. Our data on children appear highly significant for the controversial issue concerning schizoid psychopathies. The processes of schizophrenic deterioration are much more striking in the child. The schizophrenic disease process results in far greater impairment here, since the destruction of the mature psyche is accompanied by a failure of innate faculties to develop properly. All the more instructive are those cases, such as the ones we have cited, in which, despite the early onset of schizoid symptoms and their persistence in a static state, not only are there no signs of personality deterioration, but one can actually observe a continuous progression and growth of the personality. The cases we have observed compel us to conclude that there exists a group of psychopathies whose clinical presentation shares certain features with schizophrenia, but which differ fundamentally from schizophrenia in terms of their pathogenesis. The question regarding the biological, pathogenetic substrate of these forms currently goes no further than a few hypotheses. However, the clinical facts are best accounted for by the hypothesis that schizoid psychopathies arise from an innate deficiency in the very systems that are also affected in schizophrenia, though in that case under the influence of other factors.